Good day, everyone, and thank you for joining us. I'm Bill Hoagland with the Bipartisan Policy Center, and I have the pleasure of working with our health team here at the center. Uh, Today, we are releasing our second study tracking federal funding to support states addressing the opioid epidemic. Uh, the center's chief medical advisor and lead on this study, Dr. Anand Parakh, will be shortly summarizing the report's key findings, but I want to highlight a couple on my own. We identified well over 60 separate programs totaling nearly $8 billion that went to states last year, fiscal year 2019, and compared that to our previous year's study, that was about a 3.2% increase. We found about two-thirds of the funding went to programs directed at prevention, treatment, and recovery. And a small share of that funding, about 9%, was directed at interdiction, but it was also something that was almost a doubling from the previous year's spending on interdiction. Sadly, we note that the opioid epidemic is shifting with increasing deaths due to polysubstance use and sadly rising rates of overdose deaths in communities of colors. And while our study was pre-COVID, we note that COVID is exacerbating the opioid use disorder via reduced access to treatment and harm reduction. Further, even prior to COVID pandemic, provisional CDC data from shows us that at least in 2019 there was still an increase in drug overdose deaths. So today, following Dr. Parakh's overview, we will have video presentations from Representative Ann Kuster. She's a Democrat from the state of New Hampshire, and Brian Fitzpatrick, a Republican, state of Pennsylvania. Both of those states, of course, are at the center of this epidemic. And they're going to discuss the role of Congress in terms of what they have been doing and plan to do in terms of addressing this issue. We'll follow that with a panel of federal and state officials who are on the front lines of this battle every day. And a panel will be moderated by Regina LaBelle. She's a consultant on this project and formerly the chief of staff in the White House Office of National Drug Control Policy. I want to, at the outset here, thank the Arnold Ventures for their support of this study and the many, many state officials in Arizona, Louisiana, New Hampshire, Ohio, Tennessee, and Washington State for their invaluable contribution to this study. And of course, my own BPC staff who spent many hours on this project, even in a virtual environment that we've had to work in over these last many months. In addition to Dr. Parakh and Regina, I want to give a shout out to Anita Burrows, Thomas Armu, Edwin Chen, Morgan Bailey, Corrine King, and our consultant Tim Schwope, who previously was a staff member with BPC. So without further ado, let me turn this over to Dr. Anand Parakh. Anand?
Bill, thanks so much for that introduction. It's great to be with everyone today. As Bill mentioned, today we are releasing the second iteration of our comprehensive, transparent analysis looking at federal funding to support states and localities combat the opioid epidemic. We are looking at fiscal year 2019. I want to just briefly review the methodology of the report because I think it's pretty important that everyone understands exactly what we did. BPC first reviewed congressional appropriations and documentation to identify opioid-involved federal grant programs. We erred on the side of inclusion, so you'll see some programs like Simpson's Block Grant were included. We then spoke with budget officials from multiple federal agencies, opioid program levels. Third, BPC obtained state-level award information from agency sources and cross-referenced this spending information cataloged by the Department of Treasury in the usaspending.gov website for quality control. Finally, we prepared, as Bill mentioned, 6 case studies. We really wanted to assess the flow of dollars from the federal government, from Congress to executive branch departments and agencies, then to states, and then to counties and localities. And so we selected 6 states, as Bill mentioned, across the country, geographically diverse, politically diverse, some who have expanded Medicaid, some who have not, to better understand this information. And we also obtained state and county level opioid spending data for spatial analysis. Bill has already gone through the main and top findings. I want to take you through some of the takeaways from the state analysis and then focus in on BPC's 3 major recommendations. So in terms of the state analysis takeaways, number 1, the Bipartisan Policy Center found that with few exceptions, the geographic distribution of federal opioid funding has remained relatively stable, and funds are going to counties with the highest number of overdose deaths. However, it's difficult to determine within the counties whether funds are meeting the needs of those highest at risk of overdose, such as justice-involved populations, people experiencing homelessness, and pregnant and parenting women. Number 2, rates of polysubstance-involved overdose deaths are increasing, along with rates of methamphetamine and cocaine use. In addition, over the last few years, there's been increasing rates of overdose deaths in communities of color. Number 3, few individuals who are incarcerated are receiving the standard of care for opioid use disorder, although overdose death is the leading cause of death upon release from jails and prisons. States cited concerns about a lack of sustainable funding sources and access to community-based care upon reentry. States also mentioned shortages in funding for supportive housing, especially for people leaving corrections and the early stages of recovery. 4th, workforce shortages continue to limit treatment expansion, with state officials specifically mentioning that this is a significant barrier to their efforts. There is a disconnect between where vulnerable populations reside and where physicians have a data waiver practice, which stands in the way of providing treatment to at-risk populations. In addition, the majority of data waived prescribers do not prescribe to the maximum allowed number of patients. Given well-documented addiction treatment workforce shortages, several states have expanded scope of practice laws for mid-level providers, such as nurse practitioners and physician assistants, to allow them to prescribe controlled substances such as buprenorphine. States are also using federal grants to train and fund recovery support services, another key part of the addiction workforce. And finally, every state is funding naloxone training and distribution. Naloxone is distributed to law enforcement, community-based organizations, as well as to peers. However, harm reduction programs, such as syringe service programs, typically receive only limited federal funding. At the state level, several states have passed legislation sanctioning syringe service programs, although BPC found limited coordination between public health and behavioral health agencies in relation to these services. None of the states examined used federal funding for fentanyl test strips. Based on our federal and our state analysis, BPC today offers 3 overarching recommendations. The first is the continued need for sustainable funding. Though significant federal resources are flowing to states and localities, there is evidence that the support does not likely meet the need. The best evidence we have seen suggests that most individuals with opioid use disorder are still not receiving the gold standard evidence-based treatment or medications for opioid use disorder. Given this, funding for programs such as SAMHSA's block grant should be increased. It's also equally imperative that the existing funding streams be evaluated in a transparent fashion so that Congress can ensure programs are evidence-based and impactful, address treatment gaps in communities of color, and meet health equity goals. On this point, a focus on communities of color, it's critical that we address the treatment gap. We need evaluations, but we also need culturally competent trainings and interventions to increase entry into and ensure retention in treatment and recovery. The second major recommendation is the need to continue to focus on at-risk populations. Given increasing polysubstance abuse, it's important that federal grant programs allow resources to go to tackle multiple substances of abuse, such as methamphetamine and cocaine. This is what the State Opioid Response SOR grant has done, as well as what the block grant does. We need to better coordinate criminal justice efforts. There are many at-risk populations, such as those incarcerated or recently released, who are not receiving treatment. We need to increase diversion programs, increase treatment during incarceration, and treatment and have a focus on reentry. There are many ways that the Department of Justice, with SAMHSA and HUD, can work together on this issue. We need to also deploy harm reduction efforts. Syringe service programs facilitate opioid use disorder treatment and access to harm reduction. Unfortunately, there is still a federal ban on syringes. Some states have not sanctioned syringe service programs. There are few resources, little coordination, and stigma, an area where SAMHSA and CDC can also work together on. The final recommendation relates to reducing burdensome regulations and rules so that we can facilitate treatment. Congress and the executive branch must evaluate and consider extending, for example, telehealth for buprenorphine initiation, take-home methadone from opioid treatment facilities. Congress and the executive branch should also look at the data waiver and consider elimination of the data waiver and lifting the patient caps on buprenorphine treatment. In short, we need to unshackle the gold standard treatment. The executive branch and Congress and states should also look to strengthen Medicaid. That's important because nearly 4 in 10 individuals with opioid use disorders are Medicaid beneficiaries. Medicaid expansion is critical. Short of Medicaid expansion, there are many things that states can be doing, from reducing prior reauthorization to increasing reimbursement rates to encourage additional providers, as well as to expand coverage postpartum upon reentry to at-risk populations to ensure people get into treatment as well as to save lives. These are the overarching recommendations made in the Bipartisan Policy Center report. You can now access the report if you go to bipartisanpolicy.org. Again, it's all one word, bipartisanpolicy.org. I think in short, the conclusion of the report is that the federal government's current efforts are necessary and important, but need to be redoubled. At this time, we're going to move to remarks from our congressional guests. These are pre-recorded remarks. And after that, as Bill mentioned, we'll move to our panel discussion moderated by Regina with federal as well as state officials. So at this time, I'd like to introduce, we have both the co-chairs of the Bipartisan Opioid Task Force. The first co-chair, Congresswoman Ann McLean Custer. Congresswoman Custer was first elected to the House of Representatives to represent New Hampshire's 2nd Congressional District in November of 2012. Prior to taking office, Congresswoman Custer served as a longtime community activist and adoption attorney who focused her career on increasing opportunity for Granite State families. As I mentioned, she is the co-chair of the Bipartisan Opioid Task Force, and now we'll hear from the Congresswoman in pre-recorded remarks.
Good morning, everyone, and welcome. I wish that I could join you all live today, but I appreciate the opportunity to discuss an issue that's impacting families and communities in my home state of New Hampshire and every state across this country. In 2018, more than 67,000 people died in the United States from a drug overdose, with over 46,000 of these deaths involving an opioid. My home state of New Hampshire has been hit particularly hard by this epidemic. With a population of just 1.3 million people, over a 6-year period, my state was flooded with over 300 million opioid pills, and the effects were catastrophic. When I founded the Bipartisan Opioid Task Force in 2015 with former Congressman Frank Ginta, we knew that New Hampshire was a hotspot for dangerous opioid use. What we didn't know was the nuances and complexities of New Hampshire's crisis. In 2016 and 2017, we saw nearly 500 deaths, reflecting the evolution of the epidemic from pills and heroin to synthetics like fentanyl. And though the total number of overdose deaths decreased somewhat in 2018, we have so much more work to do. Today, our task force has almost 100 members of Congress from both sides of the aisle who are committed to this issue. And since our inception in 2015, we've accomplished a lot and continue to make progress in combating this epidemic. In February of this year, we released a legislative agenda which includes bipartisan common sense solutions that will improve prevention and expand access to treatment and recovery services. Just this month, in the Energy and Commerce Committee, we passed several opioid-related bills to fund the state opioid response grants and provide the flexibility to address the complexities of this crisis. And I'm grateful for the release of your second opioids report, again looking at my home state of New Hampshire as well as 5 other states on how federal funding is having an impact in our communities. In 2018 and 2019, we provided $6 billion in funding across the government for opioid response, an additional $1 billion in states to increase opioid treatment. This funding ensures that no Granite Stater is more than an hour away from treatment, and it's because of federal funding that our rural state has been able to develop a localized, sustainable approach to the crisis. One of the most important points of the report released today highlights the vulnerability of our justice-involved population. Across New Hampshire, we have seen the impact of having appropriate health care in the criminal justice system. In one of our counties in New Hampshire, a local jail superintendent invested in in-house treatment and saw the recidivism rate drop from 54 to 18%. It is my hope that we can build off the success we've seen in New Hampshire by bringing this model to correctional facilities across the country. And that's why I've introduced the Humane Correctional Healthcare Act, bipartisan legislation that would repeal the Medicaid inmate exclusion to allow justice-involved individuals to access quality health care, including mental health and substance use disorder treatment. This is an all-hands-on-deck moment, and reports like this help everyone to understand the challenges states have in ensuring there are enough resources for adequate prevention, treatment, and coordination of services. So thank you for all of your efforts, and I look forward to our continued work together.
Thank you, Congresswoman Custer. At this time, I'd like to introduce Congressman Brian Fitzpatrick, who is the second co-chair of the Bipartisan Opioid Task Force. Congressman Fitzpatrick was elected to the United States House of Representatives in 2016 to represent the people of Pennsylvania's 8th Congressional District and then the people of Pennsylvania's 1st Congressional District. He previously served as a Special Assistant U.S. Attorney focused on drug crimes and as an FBI Supervisory Special Agent fighting political corruption and supporting global counterterrorism efforts. We welcome Congressman Fitzpatrick, and now here he is in pre-recorded remarks.
Spending and for tracking the federal government. Hey everyone, this is Congressman Brian Fitzpatrick, and I want to thank the Bipartisan Policy Center for releasing their report on federal opioid spending and for tracking the federal government's response to the opioid epidemic so closely. Ann Custer and I are the co-chairs of the Bipartisan Opioid Task Force, and together we help to lead Congress's agenda on all things related to the opioid crisis. We typically hold informative roundtable discussions that help all members of the task force to learn more about the opioid issues. I have continued to advocate for more federal resources to be allocated towards prevention, treatment, and recovery efforts. While we have made progress in combating opioids, sadly, the COVID-19 pandemic has set us back, with numbers starting to go up due to various stay-at-home orders and treatment not being as accessible as it was before March of this year. We look forward to continuing to work with BPC on this important mission and hope to be able to join you all in person next time. God bless.
Thank you, Congressman Fitzpatrick. At this time, we'll move to our panel discussion. As Bill mentioned, the moderator of today's discussion is Regina LaBelle. Regina is the Director of Addiction and Public Policy Initiatives at the O'Neill Institute for National and Global Health Law at Georgetown University. Regina will be introducing our distinguished panel. I also want to remind the audience that after the discussion, there will be an opportunity for audience question and answer. We ask attendees to submit questions for the panelists using the live chat function on YouTube, Facebook, or on Twitter using hashtag BPC Live. Regina?
Good afternoon, everyone. Thanks so much for joining us today to talk about this important report. And I'm really pleased that we're joined by such great panelists who can discuss issues on the state level, what they're doing on the state level, as well as what the CDC is doing. We're joined by Grant Baldwin. What we'll do this afternoon is I will introduce each person in turn, each panelist in turn. Then we'll have a guided discussion, followed by, as Anand said, we'll take questions from the audience. And you can, I'm going to say that again, you can use the live chat function on YouTube, Facebook, or on Twitter using hashtag BPC Live, and we'll get to your questions. So I want to start first by introducing Dr. Grant Baldwin with the CDC. He's the director of the Division of Overdose Prevention at CDC's National Center for Injury Prevention and Control. And he leads that division where they look at new trends in drug use over time. He's been there for quite a number of years, and we really look forward to hearing from him this morning. So with that, I'll let you take it away, or this afternoon. Thanks.
Great. Thank you so much. Certainly an honor and privilege for me to be with you, even virtually. So as was mentioned, I'm going to outline what we are doing at CDC and frankly, how we're planning to do more. Next slide. So as was mentioned, the CDC's work in the area sits within the Injury Center in a division that was formally stood up about a year ago, although our funding for this work began about 5 years ago. We have 3 overarching goals, and you see them listed on the slide. They are to help reduce opioid overdose deaths right now. There is an urgency of the now. To address emerging drug trends that you've heard about, like cocaine and methamphetamines, and to prevent youth initiation and use. And within the division, we have 6 key strategies that address these 3 overarching goals. I don't have time to mention all of them. Let me mention just a couple. First, we have an interest in improving our ability to track trends, to use data to drive action with populations and in communities most effective. Second, we aim to strengthen state, local, tribal, and territorial capacity to scale up evidence-based programs. And finally, we aim to build or strengthen partnerships between public health and public safety to identify threats and to help link people to treatment and recovery services. Next slide. So I want to provide a little bit more detail on the numbers. You probably know most of this. We've lost, unfortunately, over 840,000 of our fellow Americans since 1999. This includes almost 72,000 in 2019 alone, or about 197 per day. And the number is getting even higher. The decline between 2017 and 2018 was likely caused by a temporary decrease in deaths from carfentanil in states like Ohio, Pennsylvania, Florida, and others. And so while prescription and heroin-involved opioid deaths are declining, deaths involving fentanyl and fentanyl analogs continue to skyrocket. And opioids are now nested in a broadening poly-drug crisis driven, as you heard, by psychostimulants like cocaine and meth. Just to summarize, geographically in recent years, there's been a westward expansion of fentanyl-related deaths and an eastward expansion of deaths from methamphetamines. And again, this is all pre-pandemic. Next slide. But because of the COVID-19 pandemic, it looks like things are going to be even worse. Staff from the New York Times queried state and local health departments, as well as medical examiners and coroners from the 14 states listed on the left bar chart through the first portion of 2020. And they found an average of a 13% increase in deaths, with deaths in some areas in the states listed here substantially higher. And data from ODMAP, a smartphone-enabled real-time monitoring tool launched by the Washington and Baltimore high-intensity drug trafficking area in 2017, supports this conclusion as well. Overall, there was an 18% increase in suspected overdose submissions when comparing the weeks prior to and following the commencement of stay-at-home orders, which began in March of this year. Next slide. So now more than ever, we need a seamless integration of data informing action, and it's essential because of the potency and rapidly shifting illicit marketplace, as well as the COVID-19 pandemic. This is a map of the 66 funded jurisdictions who are part of the CDC Overdose to Data Action Program. 47 states and 16 big cities or counties are funded, $300 million per year for 3 years. This integrates all of CDC's state-based funding into one announcement. It's about using more timely, more localized, more comprehensive and actionable data to catalyze prevention and response activities. And OD2A encompasses a breadth and depth of prevention strategies, including prescription drug monitoring programs, state and local integration, linkage to care, provider and health system supports, and others. Overall, states receive between $2.3 and $7.5 million in funds with a tremendous amount of flexibility. We just entered the second year of the program. And so for the first time, CDC is also going directly to the hardest hit counties, cities, and communities. So in addition to those 16 local jurisdictions I just mentioned, the New York Cities, Baltimore, Chicago's, et cetera, a minimum of 20% of state-based prevention funds will be used in targeted mini grants to communities hard hit. And again, that's just a floor. Next slide. Let me say a little bit more about how we're trying to track trends to inform what we do. Last month, we released a morbidity and mortality weekly report using data from 29 CDC-funded states, showing that non-fatal drug overdose involving opioids, cocaine, and meth increased between 2018 and 2019, as did polydrug overdoses co-involving opioids and meth. And those increased in all regions, among both sexes, and in nearly all age groups. And earlier this month, we published a vital signs report on all drug overdose deaths from 24 states and DC, again funded through CDC. Among the most significant key findings there, we found that more than 3 out of 5 overdose deaths involved at least one potential opportunity to link a person to care before the overdose or to implement life-saving actions, including administering naloxone. Next slide. So as I mentioned, one of the ways that CDC is broadening our work is by strengthening the partnership between public health and public safety further. A big signature program here involves our partnership with the high-intensity drug trafficking areas. We are working in 30 states as part of our overdose response strategy. We have a number of big goals with this program. They include to better coordinate data sharing between public health and law enforcement, to develop and support implementation of evidence-based programs, and to strengthen engagement of local communities and promote the inclusion of those most impacted by the crisis when designing and implementing ORS activities. And we support a public health analyst and a drug intelligence officer in each of the states listed. Next slide. Let me close with a word about a relatively new program to CDC. Actually, it's going to commence tomorrow, the Drug-Free Communities Program. With a modest investment of just $125,000, the central aim of the DFC is to utilize community-based coalitions across the 12 sectors listed on the slide to organize to prevent youth substance use. The DFC program includes a community match requirement to entrench commitment and buy-in, and a community can be funded for up to 10 years. The program was actually launched in 1998 and has grown substantially and has impacted over 2,000 communities over the life of the program. There were over 700 coalitions last fiscal year, and 1 in 5 Americans now live in a DFC community. Next slide. So thank you very much. We have very, very ambitious goals. I have a 9-year-old son named Aaron who loves baseball, and in his room, he has a Babe Ruth quote on the wall, and I think it applies to us as well. Ruth once said, "It is hard to beat a person that never gives up." That is you, that is me, and that is how we must act together. Thank you very much. Regina?
Great. Thank you so much, Grant. That was wonderful. So next up, we get to hear from Alicia Nelson, who is the director for Recovery Ohio. And Recovery Ohio is a new initiative in the Ohio Governor DeWine's office that works on the public health crises of mental health and addiction prevention, treatment, and recovery supports. So I'll turn it over to you, Alicia, to tell us more about your work. Thanks.
Thanks, Regina, and I certainly can relate to that Babe Ruth quote. It takes resilience to keep coming up and coming up with new ways to address these really challenging problems. And hopefully you guys can hear me okay. I'm getting a little bit of feedback, so if it works out, that's good. So what we wanted to talk about is Recovery Ohio. Ohio is really proud to be a part of the conference today. We were proud to be a part of one of the states that the group looked at for the report, because it's really helpful for us to have external folks come in, take a look at what we're doing in Ohio so we can really start to build from the information that we learn in the report and have real discussions about how we can continue to improve upon the work that's happening in our state. One of the things that Regina mentioned is I'm a part of Recovery Ohio, and it is a new initiative that we started in Ohio under Governor DeWine's leadership that really is set to look at prevention, treatment, recovery supports, and the law enforcement system, and discuss how all agencies within our state structure can really work together to address these problems. We all are seeing mental health and substance use disorders within our systems. We experience these things in our lives. And so to try to separate them from what we are planning for and what we do is really not advantageous to really solving the problem. So under the Recovery Ohio umbrella, of course, we have groups like mental health and addiction services agencies, but we also have strong relationships with our public safety partners, our EMS partners, as well as groups like the Board of Pharmacy, Department of Transportation, our Bureau of Workers' Compensation, and the list just keeps going on and on for us. And so we really are trying to show that all of us have a role to play in addressing this crisis. And from where we sit, we can really, if we work together, create efficient responses that use our resources most positively to get the best results we can for Ohioans. And so we've been honored to work with all of the communities across Ohio who have been honored to be recipients of things like the OD2G grant from the CDC, and really be those drug-free communities that coalitions that really are working together to address these problems, and look forward to the discussions today.
Thank you, Alicia. And next we're going to hear from Quinetta Rowley-Womack. Quinetta is the Director of Clinical Operations and the Louisiana SOR, the State Opioid Response Grant Director at the Louisiana Department of Health, Office of Behavioral Health. And we're really looking forward to hearing your thoughts on what's happening in Louisiana and any additional items you want to share. So thank you very much, Quinetta.
Thank you, Regina, so much. Thanks, PC, for the invite to have Louisiana as a part of this process, to share some of the work that's going on in our state. We are extremely excited that our Governor, John Bel Edwards, has been so supportive to the Louisiana Department of Health, Office of Behavioral Health, and other agencies across our state to support efforts to address the opioid epidemic within our state. We have released the Opioid Response Plan in 2019, in which our department, Louisiana Department of Health, is the lead to coordinate efforts with other departments to address these issues within our states. And the saying is, it takes a village. It really does take a village to address this epidemic, because we have to partner and we have to work together with other agencies and entities in order to address this as a whole for our state. But our response plan basically addressed the 5 pillars that we identified, which are making data-driven decisions, implementation of prevention, intervention, treatment, and recovery programs across the state. And we know that data is vital to making decisions. It guides our plans, it guides our initiatives, programming, and policies. We know that we have to take an approach with intervention to intercede, take a look at prescription drug monitoring programs. We're looking at increasing public awareness, implementation of evidence-based practices. As far as the intervention approach or pillar within our design, we are looking at proper medication storage, ensuring access to naloxone, drug take-back events, and other harm reduction programs. And from a treatment perspective, we're looking at access to medication-assisted treatment. We've incorporated the hub and spoke model, and we have added office-based opioid treatment providers to our workforce. And from a recovery perspective, we're looking at expanding recovery support services, peer support services, wraparound resources, and things of that nature. So we've done that with our state plan. We've done some things as far as our legislation has commissioned the HOPE Council, which is the Heroin and Opioid Prevention and Education Commission, which is composed of multiple agencies, entities, and universities that are working collaboratively to address the statewide issue within our state. And I want to just give thanks to, again, our governor and our LDH secretary who supported all of these efforts. I would like to thank all of our federal entities that help provide funding, such as CDC and SAMHSA, to help implement evidence-based programs and practices within our state, in which I will be able to talk a little bit more about those efforts during the discussion. So thanks again for inviting us to be a part of this initiative.
Thanks so much. Appreciate your comments, Quinetta. And so now I'm going to lead the group in a panel discussion. And then again, we will take questions from all the viewers. Again, if you would like to use the live chat function on YouTube to submit your questions on YouTube, Facebook, or on Twitter, the hashtag BPC Live to submit questions. So first I want to go to Grant. If you could tell us, you talked a little bit about, CDC has often talked about the wave of the epidemic. And one of the things we're seeing obviously is a lot of multiple substances that are being used that are involved in overdose deaths. In addition, so we have that, but in addition, one of the big efforts that CDC undertakes is preventing infectious disease outbreak. So I guess I have two questions. First, what are the next steps given the increasing complexity of the issue? What are CDC's next steps to bring down rates of overdose death? And if you could touch also a little bit on infectious disease prevention work.
Yeah, thanks so much for the question. So we are constantly reevaluating what we should be investing in and how we should be investing. And some of that is reflected in our overdose data to action cooperative agreement. So we have built in those flexibilities there. I talked about the opportunities for greater local investment and the more expansion prevention opportunities. So historically, our work exclusively focused on attending to prevention activities from prescription opioids. In the latest overdose data to action cooperative agreement, we flexed that out. Let me give you a specific example. So historically, we just tracked opioid-involved overdose deaths. Now we have more detailed situational awareness and circumstances surrounding all drug overdose deaths. That's a reflection of the emerging drug trends with cocaine and other psychostimulants like meth. I also want to mention, you've probably seen some reports, although it's not squarely involved with what we're doing now. There's some disturbing trends on youth cannabis use, both frequency of use and the potency of that use. So, and as was highlighted in the BPC report, some of what we're also pivoting to is focusing on those most at risk or disproportionately impacted. So this does include justice-involved populations. So what can we do to support pre-arrest diversion activities, as well as implementation or support for use of medications for opioid use disorder in jails and prisons? We believe that public health can be a bridge and a linkage safety net to those comprehensive treatment and recovery services that we know are so critical to long-term recovery. The other thing I would say is, as you know, both the change in the illicit marketplace and now with COVID-19, we are trying to support innovation, both in how we surveil the problem, but also in our programmatic work. I'll just highlight one specific example. We have a program called Combating Opioid Overdose through Community Level Intervention. We consider it like a innovation catalyst or accelerator program. And our interest is both funding that and then ultimately scaling it up in subsequent announcements. And the last thing I'll mention on the surveillance side before talking a little bit about some of the other infectious disease work that we're doing is on the surveillance side, we give each of our jurisdictions, the states at least, $400,000 per year for the life of the program to support innovative surveillance. So this could be the better use of laboratory data, linking data in novel ways. Some states are also thinking more about how can we surveil linkage to care. But as you mentioned, Regina, part of our portfolio, we are at CDC is a very large organization, so we're thinking more broadly about some of the other sequelae of opioid overdose. And so work is happening across the agency within HIV, hepatitis C, et cetera. So we stood up an opioid response coordination unit at the agency to help coalesce around a broader strategic direction that supports both attending to our sort of core drug overdose prevention, but also bridging even further into some of the infectious disease complications, which as the as the marketplace has changed to be more illicit focused, those complications are rising at HIV, hepatitis C, et cetera.
Great, thank you. I want to turn now to Cornetta and ask about a little bit more on, maybe you could expand a little bit more on the specific challenges Louisiana is facing, and perhaps how, since you work with the SOR, the State Opioid Response Grant, how is federal funding helping your state develop effective responses to this evolving epidemic?
Okay, good questions, good questions. Yeah, as far as specific challenges for Louisiana, it's an ongoing challenge as far as access to care for medication-assisted treatment within the community and within the Department of Corrections, including the challenge of treating pregnant women with medication-assisted treatment as well. These are vulnerable populations, and we are working hard to provide the necessary training. That's another issue. We don't have enough data waivered physicians and clinicians to offer care for medication-assisted treatment. There's that associated stigma myth related to treatment of MAT. Treatment of OUD with MAT. We have that lack of community knowledge around the evidence of treating opioid use disorders. And we also have that need for more education about naloxone, its availability, its utility. So with the LeSOR, one of our grants, we are working to address all of those challenges. As far as the 5 pillars that I mentioned earlier, working with data, intervention, prevention, treatment, and recovery to accomplish some of the programs that we have put in place in Louisiana. We've really depended on federal funding from SAMHSA, the Substance Abuse Mental Health Services Administration, in which we were awarded the MAT-PADOA grant, the Medication Assisted Treatment and Prescription Drug and Overdose Abuse grant, the State Targeted Response Grant, the Louisiana State Opioid Response Grant. We also received funding from CDC for the Opioid Surveillance Grant, where we created what we call the LODS system, the Louisiana Opioid Data Surveillance System. And we've received other funding from FEMA, implement crisis counseling programs and things of that nature. So we were able to implement what we call the hub and spoke model, which is basically partnering with opioid treatment programs across the state, creating for access within our office-based opioid treatment programs in the community, and allowing them to negotiate with one another, partner with one another, because we all see the same clients, right? So we want to have better relationships so that we can provide the necessary services for those individuals. And just a few things that we have done as far as things that we're proud of, things that we have accomplished because of these federal dollars to support the state of Louisiana. We have really been able to increase the number of office-based opioid treatment providers in our state. We now partner with 48 additional providers that's seeing the under and uninsured populations now that weren't seeing that population previously. So that's a big, big win for us. We have also implemented what we call spoke care teams. We have 10 regions across the state of Louisiana. And one of the things that physicians have told us over and over again is that they needed support in order to treat this population with MAT. They just didn't have the capacity to provide that service with the necessary quality of care. So we listened, we heard what they were saying. And so we designated a registered nurse and a licensed mental health professional as a team, in which we call the spoke care teams, whereas they are working with those individual data waived physicians, providing all of the necessary reports that are needed, supports that are needed. They are providing screening, brief intervention, and referral to treatment. They're also providing like case management services, linking clients to other wraparound services for the physician. So it's a warm hand that's helping the physicians out to provide that vital service. We have also been able to create 22 additional recovery support homes for persons with OUD. We target persons with OUD with some of these federal dollars so that they can have a safe recovering environment once they are back in the community after leaving treatment. And we also successfully partnered with the Department of Corrections to expand capacity and provide medication-assisted treatment services within 5 of our prison systems. And to date, we've served about 163 people in the prison prior to release. Once they are released, we have peer support liaisons that's working with those individuals to help them transition from incarceration to safe recovery homes and providing resources within the community, whereas they can have ongoing care. So we won't have that gap in care and they would have a continuum of care. We've treated about 15,000 people as far as trainings and educations in our state. We've provided 1,100 evidence-based trainings as well. We've treated about 2,700 clients that were enrolled in our opioid programs with the targeted response grant. So these are just a few. If I had more time to speak, I can go on and on about the different strategies, approaches, policies, and legislation that we have implemented to try and tip the scale at all. And so that's where we are in the state, a brief nutshell as far as some of the things that we are doing with our funding.
Great, thanks so much. Alicia, I want to turn now to you. Ohio's certainly been in the middle of this for quite some time, facing various phases of the addiction epidemic, and certainly your governor, when he was Attorney General, was very much involved in this issue, and continues to be as governor, as reflected in your position. So, if you could tell us a little bit more, it looks like Ohio has that the 2018 numbers, you saw a decrease, and now you're seeing increases that started in 2019 are increasing today. Perhaps you could tell us a little bit more about, number one, what you all are doing, but also what more can the federal government do to help your state in light of these trends?
Well, thank you. And yes, unfortunately, we're finalizing the 2019 data now, and formal reports will come out on that here soon. But preliminarily, we are having conversations about how we can and why it's not time to take our foot off the gas, and how we can really continue to push for the continuation of these support services and innovation. I think that's a word I've heard thrown around today, because we know that we are going to have to continue to be creative to reach more people, and really address this crisis as it continues to evolve. And we all know that we're dealing with fentanyl in everything. We're seeing that here in Ohio. We're seeing that impact a number of new populations. And in terms of support, we really want to have conversations with folks across the country and get support and continued support. The federal government has been tremendously supportive through our work and efforts through the SOR funds and many of the grants that were mentioned that have been given to other states like Louisiana. But one of the things that we're having a lot of conversations about are how do we reach communities of color, and how do we bolster a workforce to make sure that they have the cultural competency aspects built within to really have those hard conversations or new conversations or continue conversations in communities of color. Because what we are seeing is high rates of overdose deaths in African American males. And those numbers are just a sample of what we're seeing in Black and brown communities across our state as the drug trends go towards fentanyl mixtures with cocaine, and continued overdose deaths when it comes to methamphetamines and fentanyl mixtures. And so that 2019 report is being finalized as we speak, but we're really concerned about the national trend as well. And I'm sure that my colleagues across the country are experiencing this too, with COVID-19, and how we make sure that we maintain our recovery community in this very challenging time. Stress and anxiety is something that we're all, or many of us, are experiencing right now with everything that's going on, and making sure that our communities know behavioral health remains open is important, and that people are there for folks is going to be important. So all of the support that the federal government has given us to expand telehealth, we really ask that continue. We really ask to work with our federal partners and others across the country to figure out best practices to continue this work, and really dive into who it's working best for. And what models and modalities of this service will be most beneficial to continue permanently. And so we'd love to have conversations about that. But just as a snapshot, those are some of the things that we're working on in our state.
Thanks. So we have about 7 minutes left for this session, for this portion of the discussion. And I think I want to ask each one of you to answer the same question, if you wouldn't mind. And perhaps beginning with Grant, if you could tell us a little bit about how your agency, how does CDC responding to the needs of states in light of COVID-19 and the challenges that people are facing accessing treatment and other issues?
Yeah, so I'll mention a few things. I think I've mentioned flexibility in funding, both sort of program redirection, reprogramming of funds, or redirection of funds. We're also, as part of what we're trying to do, is fund special projects that catalog what states and localities are doing in an attempt ultimately to bundle those together and push them out to showcase to others what innovations can and should be brought to scale. So those are, I think that's one big specific example. I'll give you one highlight that actually is happening in Ohio in the Overdose Data Action Program. We have a county in Ohio is increasing their presence on social media and using text messages to market some of the novel services they have available, and sending out information on harm reduction and naloxone to subscribers. I think the short answer of what we're doing is supporting flexibility in how our dollars are used, and adequately reprogramming or redirecting funds as allowable in the context of our funding. Again, focusing on innovation, focusing on flexibility.
Quinetta, can you tell us a little bit more about the challenges that you all are facing in terms of addiction treatment during COVID, and perhaps a couple, just a brief mention of some of the things that you're doing?
Yes, we are definitely facing some challenges due to COVID. As we all know, the rate of use has increased due to all of the additional stress and anxiety that goes along with COVID. And we also have the issue on the other side, whereas providers are having great difficulty with admissions at this time because of COVID. So lots of behavioral health providers are really in a situation whereas they want to provide services, but they also want to keep clients that are currently in their care safe. So because of the help of one of the grants we received through SAMHSA, we are able to implement a specialty program, whereas individuals from across the state, if they are in need of treatment, if they are even positive for COVID, there's a place to receive access to care. And we think that's huge. That's big because we want everybody to be safe. And we want to continue to provide these invaluable services to our population. So we do have ASAM level 3.5 facility, residential facility for any individual that's in need of substance use care, whether it's strictly substance use or an opioid use disorder. We do have care available for them. We've also implemented behavioral health warm line. If a person is just under duress, if they just need to talk, if they need a referral to care, if they're struggling because of the stress behind COVID, it's impacting their mental health, it's impacting their social life, could impact their physical health as well. We have a warm line, whereas an individual can talk about what's going on with them, Johnny on the spot, and make the necessary links and referrals within the community. So that's a few things that we're doing in the state right now.
Great, thanks. Alicia, I want to give you the same opportunity to talk a bit about how you're responding to COVID in the time of the epidemic meets the pandemic.
I think we're doing a lot of what was discussed. I think, we've already talked about telehealth and how important that's been. But what we are trying to continue to do is work to be a few steps ahead of and anticipate the needs of the community, understanding how these challenges will evolve over time. So we too have the COVID care line where we can, and individuals can across our state, call 24 hours a day to just talk, seek treatment and get support. We have telehealth. We've looked at different ways to get naloxone out. We've looked at mail order programs. We most recently just passed House Bill 341, and we are excited to be able to now in Ohio have things like naloxone vending machines to continue to find ways to make the supporting tools that folks need available. But, really talking about what's next is one of the things that we're working on right now, and that's around mental health and how we can improve the mental health of Ohioans and what things we can do to embed mental health in schools, mental health in our communities, and make the conversation okay to talk about that. And regardless of whether the person is dealing with someone, a family member struggling with substance use disorder, or just, increase anxiety and stress because of COVID-19, not feeling shame or stigma, to make sure that they reach out and discuss have those conversations with either a family member, a loved one, or a professional. when needed. And so I think that that's going to be a huge part of how we move forward next in trying to find ways to put screenings and interventions in new ways, in new places. As Dr. Baldwin mentioned, we definitely are seeing that there are opportunities that we are missing, and we want to make sure that we capitalize on any opportunity to engage in a person's health and well-being in Ohio.
Great. Thanks so much. That was a wonderful opportunity to hear from each one of you about the great work that you're doing. And now we're going to turn to questions that we've received from our viewers. And I want to remind folks again that you can submit questions using the live chat function on YouTube, Facebook, or Twitter using hashtag BPC Live. So the first question we have is from Nina from Twitter. If you could tell us a little bit about increased opportunities for public and private partnerships to address the issue of the addiction epidemic. And I'll leave it to the three of you who would like to answer that question first, if you have some thoughts.
Sure, this is Grant. I'll go ahead and start. I think one of the things I mentioned with our drug-free communities is that last slide showed the 12 sectors that are involved in that program, and one of them is the business sector. I think we're at a point in time, given the scope, scale, complexity of the epidemic, that all solutions are on the table, including novel public-private partnerships to get us where we need to go. I think that's a program that codifies the need for that public-private partnership, but even within the context of our overdose data action program, I think there are real opportunities, and states have the degrees of freedom to do just that. And finally, with the locality investments, again, that's another place where there seems to be a lot more degrees of freedom for those public-private partnerships. So we absolutely agree with that there's a real opportunity, an untapped or under-tapped opportunity to leverage those novel partnerships.
That's great. Any other questions?
And I agree.
Right.
I was just saying, I definitely agree with that. There's definitely opportunities for partnerships. We have to have it. There's no way around it to address the opioid epidemic from a state and national level. We can't do it alone. We welcome partners. We reach out to our local governing entities for partnerships. We look at our other agencies for partnerships, private providers. We all have to come together again as a village in order to tip the scale at all. So there are opportunities for partnerships, most definitely.
Thanks. Alicia, did you have anything to add?
Well, I would just, echo what has been said. And I think that more and more we are learning from each other, from a private perspective, from a public perspective. We look at things differently sometimes, and that brings us together in a way that comes up with new and innovative ideas. Here in Ohio, we have a partnership around the group called Deny Ohio, and they really are working to decrease stigma. And their marketing strategies, it's in partnership with the Nationwide Foundation, are things that we've never had access to as a public entity. And so they've been able to really get the word out around stigma and do things that, that government entities aren't usually able to do. And so those partnerships, I think, are going to be crucial and just mutually beneficial, because individuals with mental health and substance use disorders aren't in one segment of the population. And so the more we understand each other and work together, I think the better it will be in our responses.
Great. Thank you. One question that came up is the level of support. Obviously, the resources that we've looked at, over $7 billion is going to states. Next year, I think that obviously we're going to see reductions in tax revenues for states. And so I have a question for Alicia and Quinetta. the federal funding goes through states and you spend it as you need to, but you also rely upon state funding. So what are you looking at for next year? I think a lot of state and local governments are going to be looking at budget deficits that they're going to have to fill. So how is that going to affect the work that you do? And looking around the corner, what are your thoughts on that? And Alicia, if you want to start with that.
Sure. Much like the rest of the country, we're grappling with this now. Proactively, we did take a 20% reduction and really looked at how to streamline services. And I think the name of the game moving forward is going to be efficiency. And how can we make sure that we're using all of our resources in the best ways possible? And that takes collaboration. It takes conversations across agencies, which I'm happy to be a part of the Recovery Ohio team to convene those conversations. Many times, our agencies become their own silos. I'm grateful to say that this administration is really trying to look across agencies to figure out who all is funding what and how we can work together to fund different pieces of it. I think that, as we become more and more creative with this, we're going to need some of our federal partners to continue to be flexible with us. We really have appreciated the flexibility that we've been afforded, but it's going to take some of those creative solutions, flexibility, and efficiency to really do more with less. And I think that that's going to be the challenge that we'll keep talking about for the next few years.
Thanks. Quinetta, did you want to add anything to that?
I basically would like to mimic, what she just represented. We all are looking at budget deficits, and we all are looking for efficiencies, yet continue to provide effective services. So the whole purpose of us developing that Hope Council and developing those partnerships so that we can look for duplication of efforts that reduce costs, and that helps with efficiencies if we're all able to look at the full spectrum and look at the full continuum of care and find those areas where we can save. So absolutely, I mimic and ditto what you just said.
Great. And Grant, I think you responded by, pointing out the flexibility that CDC and federal funding would have. But if you have anything, do you have anything else to add about how the federal government can be a good partner for states that are facing financial hardships in the coming years?
Yeah, I think I would just add that, as you indicated, we just need to partner together. I mean, this is an active conversation. Obviously, when the large cooperative agreement was put out, we were pre-COVID and sort of weren't in this time. So I think we need to be fluid and flexible and just work with one another. I mean, we all have the same aim in mind here, which is to reduce drug overdose deaths. So as long as it's within scope and our budget offices sign off and it's evidence-based and sort of focused on the data, I'm all for it.
Great, thanks. So we have just a few more minutes and before I turn it back over to Anand, but I wanted to ask if each of you have some closing comments about anything that you think people should know about your efforts, either at CDC or in your states. And Quinetta, do you have a few closing comments that you'd like to make?
Absolutely. I'd like to just say that it is helpful and beneficial to the states to receive the different types of federal assistance from SAMHSA, CDC, FEMA, the leadership of our governor, the leadership of our secretary for the Louisiana Department of Health. All of those different supports matter. If we don't have those supports, we can't implement new programming, new policies, protocols, and initiatives to address the epidemic that we're facing. And now we have an additional COVID pandemic on top of that. So I just want to thank you all for the opportunity to participate and talk about some of the great things the state of Louisiana has gone on, but it's not happening without you, without all of our partners.
Thanks. Alicia, do you have any closing remarks? And then I'll turn it to Grant.
I absolutely want to thank all of the partners at the federal level, at the state level, across state lines. I've reached out to many folks across the country for support and ideas and answers. I think we all are in this together to figure this out together. And I've appreciated those conversations and the grant support that we've received. I think Ohio is really recognizing that we're all in this together, but we're not all in the same boat, and really appreciating each other's differences, looking at problems from a variety of perspectives is, I think, going to be the key to how we really start to see change in the numbers. And continue to be creative in ways to do that with limited funds. So I appreciate everything that everyone is doing. Make sure we are all taking care of ourselves. This is one of the things that I've started to say everywhere I go, because this is a tough time for everyone. And before we take care of others, we got to make sure we're taking care of ourselves. And so if you haven't done so, take a moment and really take care of yourself right now, and make sure that we can all sustain and be resilient as we try to tackle these problems in the future.
Thank you, Alicia. Grant, closing remark?
Yeah, Alicia, that was really extremely well said. I want to echo what you just said. Thank you to BPC, and thank you to everybody on the webinar for participating. We are eager to be an active partner with all of you and shifting and pivoting what we do, both as your needs change and as the needs of the epidemic demand. Push us. I think we need to push each other while we're also being tender, as Alicia just mentioned, as we sort of wrestle with the drug overdose epidemic as well as COVID-19. But I think there's a real opportunity. We ultimately will get ahead of this and make a difference, and those numbers will come down. We just need to be flexible and nimble and patient and understanding, and we'll get there. I'm very confident in that, and it's actually the dollars that Congress appropriates to us that we work with all of you on sort of help us get to that point, and we are eager to support your work. Thank you very much.
Thank you, Grant. So before I turn it over back to Anand, I just want to thank our panelists and BPC for the report, for all the work that you all do in each one of your states every single day. It can be kind of daunting sometimes when you think about having worked on this issue. We're entering our third decade, and the addiction epidemic has been with us for even more decades. But hopefully we're shining a light on the issue, and we're going to tackle this in a science-based way going forward that's going to make a difference in the lives of people who need help. So Anand, with that, I will turn it back to you.
Regina, thanks so much. And I also want to echo your comments and thanks to the panelists. It was extremely informative. Thank you for your leadership. I want to thank the audience for your participation today and in viewing this event. As Bill mentioned, I want to thank the Bipartisan Policy Center staff. I want to thank all of our federal and state partners who made this report possible. Thank you. And I hope everyone can go onto the bipartisanpolicy.org website and download the report there, and please take a look at it. We hope that there's informative data for you, whether you're a policymaker or just want to be informed about where we are with respect to the epidemic. I also want to remind all of our viewers to subscribe to the BPC YouTube channel for notifications on upcoming live events and more BPC video content. So with that, thank you so much, everybody, for joining us. We really appreciate it, and look forward to continuing to work on this very important topic with you in the months and years to come. Thanks, everybody.